Good evening, everyone. A warm welcome to all those who have joined with us live today for the special session World Bipolar Day 2025. I am Dr. Raghunandan R., postgraduate resident in the Department of Psychiatry, Amrita Institute of Medical Science, Kochi, along with my own co-PG, Dr. Naveen R. Pillai, psychiatry resident in Department of Psychiatry, Amrita Institute of Medical Science, Kochi. Here, it's our pleasure today to introduce the today's event hosted by Medusane. Every year, on March 30th, it is observed as World Bipolar Day, commemorating the birthday of legendary artist Vincent van Gogh, who was posthumously believed to have bipolar disorder. This day serves as a social initiative in raising the awareness, combat the stigma, and foster a better understanding on this disorder. It is crucial to recognize that this disorder is affecting millions of people and it is influencing the mood, energy, and the daily life of these people, those who are affected with. By encouraging an open discussion, we can promote an early diagnosis, effective treatment, and more compassionate society for those living with these mental health challenges. At Medusane, we are committed to make the medical education accessible and impactful. We want to bridge the gap between the theoretical knowledge and the practical aspects in the medical practice. We provide high quality medical education through expert led lectures, skill development programs, and engaging digital content. We assure that these sessions are definitely going to play a vital role in shaping the future of medical learning.
So, today we are honored to have Dr. Bindu Menon, an esteemed expert in psychiatry, as a keynote speaker. Dr. Bindu Menon, currently serving as a professor and head of Department of Psychiatry and Behavioral Medicine at Amrita Institute of Medical Sciences, brings with her over 25 years of experience in mental health. She completed her postgraduate training at GS Medical College, Mumbai, and later worked at NIMHANS, Bangalore. Throughout her career, she has contributed significantly to various sectors including government, private, corporate, and NGOs. Her expertise spans neuroscience, community psychiatry, de-addiction, and psychotherapy, with a keen interest in the intersection of psychiatry and spirituality. Beyond her medical and academic achievements, she is also a passionate writer, known for her insightful short stories and poetry, reflecting her deep understanding of human emotions. Her dedication to teaching and mentoring young minds makes her the perfect speaker to help us navigate the complexities of bipolar disorder and its impact on mental health.
Without further delay, let's move into the session. Ma'am, what made you to choose this field, psychiatry, and what is the journey you have done so far?
Well, psychiatry, I believe, is the last unexplored frontier. Just like the universe is something that is mysterious, I've always found the human brain and the mind is something that we do not fully understand. So that has always fascinated me. And I have a personal brush with mental illness in the sense that my grand uncle used to suffer from schizophrenia. At that time, there was no treatment available, and I've seen how people treated him and how he was not getting the correct kind of treatment. So I think that also must have affected the reason why I took up psychiatry could be both of these things.
Thank you, ma'am. Bipolar disorder is often misunderstood. Could you briefly explain what it is and how it is different from the normal regular mood swings?
All of us have mood swings. If you look at our moods, one day it will be slightly low, another day it could be slightly up. So there is something like a small wave pattern in our mood swings. But some people have it really, it goes really haywire. So there are like ups which are very, very bad and downs which are very, very bad. But again, this is not from day to day. So what is meant by bipolar disorder is that people misunderstand it's not day to day fluctuations. It is a period of fluctuation where in that period for lasting for at least 1 or 2 weeks, where the person has intense mood swings, either upswings or downswings, and that affects all areas of his functioning. So only that is can be called as a bipolar disorder, and there are intervals of normalcy in between. So this is technically what you mean by a bipolar disorder.
Okay. Ma'am, how common is this bipolar disorder in India and how do we see the difference in the prevalence across the age group, across the gender, and across the ethnicity?
Bipolar disorder overall, from the WHO statistics and Indian statistics, we have zero point 0.4 to 0.5 out of that's percentage. So that means it affects almost more than 40 million people all over the globe. It is equally prevalent in male and female. And there are a lot of genetic components to this disorder, more than what is found in any other, like anxiety or depression. So it seems to be a biological uh, problem in the both in the genes as well as all psychiatry is basically a combination of genetic and psychosocial environment, the interface between these two, which produces the illness or the phenotype. So it's fairly prevalent in the sense, but not as prevalent as depression, say.
So, now that we have scratched the surface of bipolar disorder, let us ask ma'am about the diagnosis and clinical features. So, ma'am, what are the early warning signs of bipolar disorder the people, including us doctors, should be aware of?
Yeah, so the early warning signals would be decreased sleep or the decreased need for sleep. That is the first symptom that comes up. So the person becomes very energetic. It's like as if 24 hours are not enough for him to do or her to do whatever they want to do. This is often the complaint. I have so much to do and I have so little time and I don't need to sleep. Sleep is a waste of time. So that kind of attitude comes up. Secondly, they start talking a lot sometimes. They start interacting. A person who was maybe very shy or introverted suddenly blossoms into somebody who's an extrovert, goes for parties, talks to everybody, calls up people on phone. And subjectively also they have a sense that their thoughts are racing. So these are the early signs. But they feel a lot of ideas are coming to one after the other, and they have this tremendous feeling of increased energy and euphoria. I would say that is what is called the hypomanic stage. That means less than mania, but a beginning of something.
Right. So, ma'am, we often hear about bipolar 1 and bipolar 2 disorders. How do these two differ, ma'am? And why is this classification so important?
Bipolar 1, there is a classification which includes up to 6. Bipolar 1, 2, 3, 4, 6, 5, 6 actually. That's called like a scales classification. So actually, but now what is being used is bipolar 1 versus bipolar 2. So in bipolar 1, you have classic mania and depressive classic symptoms, or may not have depression at all, but classic mania is definitely there, which I mentioned earlier. All the symptoms of increased energy, increased talk, mood is elevated, hyperactivity is there, sleep is decreased, and sometimes there are psychotic symptoms of grandiosity, feeling that you're very great or somebody very powerful. So this is classic mania. So when you have classic mania, it is bipolar 1. Well, what happens in bipolar 2 is that is often mistaken for personality. Again, there's a confusion with borderline personality because most of the episodes are depressive and very bad depressive episodes, and they kind of go on and on. And they are punctuated with episodes of hypomania, which I described earlier, the early ones. So they seem to be as if they are always lazy and they are always moody and they are not, productive most of the time. But there are brief episodes where they suddenly become very active and start doing a lot of things, only to be dragged down by the depressive episode when it comes. So it's rather unfortunate to have a bipolar 2 because it can be a very nasty kind of bipolar. The hypomanic episodes are also not syndromal, so many times it will be missed. So you'll see a person who is chronically dysthymic or having always a low mood. So it can be misdiagnosed, number one, so it's not treated properly. Two, it is difficult to treat. It is much more easier to treat a bipolar 1 manic episode with all the disruption despite being so disruptive. The treatment is better in the sense they respond better to mood stabilizers. Whereas in a bipolar 2, first of all, the diagnosis is missed, so antidepressants may be given that can worsen the mood instability. Secondly, it may be mistaken for a character or personality disorder. Again, diagnosis is missed. And also, if you start treating it, it is rather difficult to treat. So that would be why bipolar 2 is often something which is called as a soft bipolar, which is missed often. And I think what we mentioned, the incidence and prevalence must be much more as compared to what is actually detected now, because many of these disorders are completely missed and people don't understand that they have the disorder unless you really look into what they have.
Okay, ma'am. Right. So, ma'am, now moving on to how does bipolar disorder typically present in children and adolescents? Because that is a very difficult topic for everybody in general. So is early diagnosis possible in those cases?
It's a little difficult in children, especially in children. Adolescence, of course, that is when it first presents. Most of the time, it is similar to that what happens in adulthood, and it usually presents around the age of 14 or 15. So, adolescent onset bipolar disorder is quite common. Now, in children, what can happen is it is often misdiagnosed as ADHD sometimes because they are so hyperactive, they are so disruptive. So there can be a lot of acting out behavior, conduct problems. So we are not quite sure what we are dealing with, whether this is attention deficit hyperactivity disorder, and the treatment is totally dramatically different. For one, you give stimulants; the other, you have to give more stabilizers. So you give stimulants, you worsen the person's bipolar disorder, child's bipolar disorder. So it can be a little tricky there. So it's difficult to diagnose. Again, difficult to treat also.
All right, ma'am. Right. So now, as you all know, many psychiatric disorders overlap in symptoms. So, how do, ma'am, expert psychiatrists such as you differentiate bipolar disorder from conditions like depression, schizophrenia, or like you mentioned earlier, borderline personality disorder, ma'am?
So we have certain criteria which we use, which the diagnostic systems are there, which classify mental disorders. And the reason these criteria exist is so that we can differentiate the disorders. For example, we use ICD-10 or DSM-5, which is coming to ICD-11 has come. So using those criteria, those are guidelines for us to differentiate between something called schizoaffective, because there are symptoms of affect as in mood, which are present in schizoaffective disorder. So we may be inclined to think whether they have mania or is it mania with psychotic symptoms. Ultimately, there is a lot of overlap in psychiatry. So often we find a mixed diagnosis rather than a straightforward diagnosis. A bipolar depression typically manifests as a very severe depression with a lot of lethargy and a lot of lack of energy and a lot of very severe mood disruption, and that can be a pointer towards whether this is a bipolar depression or not. Borderline personality is a long-standing. When you say personality, it is a long-standing, uh, attitude. The way the person reacts to stress, the way the person conducts his interpersonal relationships. So it's more prolonged and it is more chronic. It's not episodic. So, but it takes a little time to differentiate between these two. You have to take a very, very detailed history. That is the only way you can many a time differentiate.
Right. So, as you can all see, there is a lot of confusion here, but ma'am has explained it clearly. So, better watch out for the symptoms.
Thank you, ma'am. That was an insightful answer so far. Diagnosis and clinical features have been so far beautifully explained, which was asked by Dr. Naveen sir. Now, what are the current treatment options available for the bipolar disorder, and how are these treatment options evolved over the years?
Earlier on, there was no difference between any kind of mental illness, so everything was considered the same. But it was Emil Kraepelin, who split psychiatry into two major mental illnesses. One was the episodic, better prognosis bipolar disorder versus the schizophrenia, which had a worse prognosis and a deteriorating course. So he divided mental. He was the first one to classify mental illness into two. So you were asking about the treatment options. Bipolar disorder basically is an episodic disorder. So what is the reason for treating is to prevent further episodes and prevent even more increase in the frequency of the episodes. So the inter-episode interval is cut because of the medication, and the patient has to be maintained on medication. So what are the medicines which are used for bipolar disorder? Usually what we use is a set of or a group of medicines which we call as mood stabilizers. So what are these mood stabilizers? Classically it was lithium first, and then it evolved to other group of drugs like many medicines which are used for epilepsy are often used for bipolar disorder also. So there's a bit of confusion. So many patients ask me, why am I getting anti-epileptic drugs? But these are very good mood stabilizers like valproate, lamotrigine, oxcarbazepine, carbamazepine. All these are also used in epilepsy, but they are also used in bipolar disorder. Lithium was a classical prototype anti-manic and antidepressive drug. It is still continues to hold a very good important place in treatment. The third kind of treatment would be with brain stimulation. So you can use anything to stimulate the brain. It could be what is called as electroconvulsive therapy, which is classically used. It could also be RTMS, but there are less results or less studies based on those things. But ECT is a very good treatment for improving either a depressive episode or a manic episode.
Okay. Ma'am, actually you would have seen lots of patients. When these patients comes to you, they would be first resisting the pharmacotherapy, that is the medicines. So most of them ask you, can the lifestyle modifications improve my bipolar disorder or improve my mood fluctuations? Ma'am, as a psychiatrist and as an experienced person in the field so far, can you just let the people know how this diet modification and lifestyle modification is going to play a role in stabilizing mood of the person with bipolar disorder, and is it that alone necessary?
That is the third kind of treatment I was going to mention, is that improving the biorhythmicity, that is your sleep-wake cycle, all that affects your mood. But in a very, very severe case of bipolar disorder or acute manic stage or acute depressive stage, just that doesn't help. It is an adjunct treatment to, lifestyle is definitely important, but it is more important to prevent a relapse and to mitigate the symptoms rather than as a full treatment. So you can't just have only that. You will have to have drugs. So it is a brain disorder which requires treatment, just like any other psychiatric disorders are all brain disorders. There, for us, the concept of mind is that it is a functioning of the brain. So if there is no brain, there is no mind. Obviously, for us, though many people may believe differently, it's a controversial subject. We'll not go into that. So for us, we are primarily behavioral neurologists. So it is something wrong with the brain. You have to give medicines to correct it, which is why anti-epileptic drugs act to correct the symptoms, as you can see. So we cannot rely only on non-pharmacological methods, though they are definitely important to prevent episodes, to improve mood functioning, even in normal people. Now you have a number of soft bipolar symptoms. Now that is another, when it comes to classification, I'll probably talk about that. But many of these soft bipolar symptoms can be tackled by lifestyle modifications. That is, sleep at the right time, wake up at the right time, have your meals at the right time, do a little bit of exercise, eat healthy, don't use junk food. All these things are part of any kind of mental health issues which can be used in these also.
Yes, ma'am. From your answer, I can just understand and also assure the people that medication, along with all these adjunct lifestyle modification, will definitely help, and not just lifestyle modification is going to give a 100% results in the bipolar disorder.
Definitely.
Ma'am, actually, many people, as I already told in the previous question also, they have some sort of hesitation to take a drug. Can you please explain that? How this mood stabilizer are going to have a long-term impact on the patient, because most of them searches in the Google and tells, ma'am, this has side effect, this is going to have this problem. So how do you convince the people, ma'am, as a patient of yours?
We have to tell them that the episodes that come are going to be more disruptive than the side effects of the medication. Definitely they have side effects. So we explain a lot of side effects to them. But looking at the side effects, they are very, very minor compared to what disruption happens in the patient's life because of a manic episode or a depressive episode. We have to understand that these are disorders which really affect not only the patient but also the people who are around the patient. So, for example, in a manic episode, the person may make very, very foolish decisions regarding finances, even interpersonal relationships. I have had patients who have divorced their wives and gone and had a lot of girlfriends, and then they come back and what did I do with my life? So, instead of going into that, it is definitely better to have some side effects. This is what I tell the patients. But many of them, as you say, are very reluctant to take medicines. One is because bipolar disorder in the manic phase and even in a very severe depressive phase, they do not have the insight that they are mentally ill or they have an issue. So it's often forced admission and coerced medication, and so that happens. That has to happen because they do not understand the implications of having the disease.
Right, ma'am. Ma'am, and this is going to be just a continuation of the previous question. We have this sort of like confusion whether I need to go for a therapy or whether I have to choose the medication. So, as a psychiatrist, how will we approach this? Which comes first, therapy or medication? How we will be handling it?
It depends on the severity. Suppose you have a very mild depressive episode, then I can suggest cognitive behavior therapy if the patient is not willing to take medication. But in a severe depressive or a severe manic episode, we cannot leave the patient like that for just for therapy is not going to help there. That person definitely needs medication. And like I said, to prevent episodes, you do require medications. So otherwise, you leave the patient with therapy. Okay, everything is fine. But then another episode happens. It may not be the same depressive episode. It may be a manic episode where the patient loses all insight. So when the patient loses insight, you can't do therapy. Therapy can only be done with somebody who understands and who can introspect. So the very definition of a manic episode is that patient has no insight into the problem or loses insight once it becomes severe. So you have people who have hypomania or very early manic symptoms who understand, oh, something is going wrong with me. That happens after a couple of episodes and they come immediately. In fact, I've had patients tell me, okay, please increase my medication, I'm going a little high. So I've had that experience. And then eventually they understand that what is happening.
Okay. Ma'am, actually recently we had a patient in our ward. So when the patient was coming with a manic phase, the person was asking whether you will give me a shock like it is given in the movies and other things. These movies are influenced about so many things about the ECT, which we commonly call it electroconvulsive therapy. So can you just give an insight for public as well as for the medical students that what exactly is ECT in a brief way so that they can just help with their relatives and friends regarding what exactly it is?
ECT is the most misunderstood and stigmatized treatment in psychiatry, as all of you know. All the cinemas which have been showing these electroconvulsive therapy has shown them as something to make the patient even more madder. So it's a bit of a comedy sometimes, or it's always the patient. The doctor says, okay, take him to the ECT room, and then he's directly it's as if he is plugged into the DC, and then everything he gets convulsions. So that's not how it happens. You have to take, and we do it. What we do is modified ECT, and it stimulates certain areas of the brain only. So there is a current passing through the skull into the temporal lobes. So that is where the mood, the insula, and the temporal lobes are the seat, or the limbic system is where the emotions are supposed to be focused on. So that is the area we pass the current through. Even other newer treatments like RTMS and neurologists are doing this for stroke and other Parkinson's disease, but nobody has stigma about that. But not ECT, but other kinds of stimulation. Basically, stimulate those areas. That is what is meant by whatever means. But electroconvulsive therapy really works for bipolar disorder. In fact, it is probably the first indication for bipolar disorder, especially bipolar depression.
Okay. That gives a clear idea for not just for public but also for medical students so that they can just take this to the general public. Those who are watching this video, you can just do it. Ma'am, many patients struggle in the bipolar disorder with one particular point where they are not adhering to the drugs. So when they get discharged from a ward, they basically don't adhere to the drugs and come back to us again. So how do you take this as a challenge as a psychiatrist and how you deal with it, ma'am?
That is true for all psychiatric disorders, not only for bipolar disorder. That patient will not comply with drugs because of various misconceptions. You go to a pharmacy or a medical shop, then they tell you why are you taking this medication? This is for major mental illness. So then they get stigmatized. They get a little embarrassed. They don't want to go and buy the drug. They don't want to. They start feeling scared that why am I taking this drug? I'm normal now, so why should I take the drug? So these kind of non-adherence is common with all psychiatric disorders, especially so in bipolar because they become absolutely normal in between episodes. So even their relatives start feeling, okay, why should he take this drug? It has so many side effects, makes him dull, it makes him sleepy. Why do you want to continue? The thing about this is that we have to educate the patient and the relative that we will not be giving very high dose once a patient's symptoms have settled. So we will be actually reducing the dose over a period of time, and we will be maintaining only the drug which is required to prevent relapses. But that happens over a period of time. It cannot happen immediately. As soon as the patient is discharged, if we withdraw all the drugs, he is again going to go back into the same stage. The second misunderstanding happens when the patient becomes depressed. So what happens when the patient becomes depressed is he starts sleeping a lot, he will not get up from his bed. So again, relatives think, oh, it is because of the medicines that he is becoming so dull. When actually it is an episode of depression. So these misunderstandings are what cause non-adherence. So unless you educate the patient and the relative, you are going to get this non-compliance and relapses. And that's the sad part of it, is that each relapse is even worse than the previous one, and it takes time for it to recover.
So thank you, Dr. Raghu, for about the treatment and management. Now we are moving on to a topic which you have already given us an insight about the stigma, the public awareness and the stigma. So I want to start off with asking you: there's a strong stigma around mental health in India, as we all know. So what are the some common myths about bipolar disorder that needs to be debunked?
There are lots of myths about mental illness in general and in bipolar disorder in particular. Because sometimes when the patient is just hypomanic, nobody understands that he has a problem at all. Or even depressed, then the person is so lethargic and so dysfunctional that their relatives often call them lazy. So first of all, the understanding is not there. So they say, this fellow is just lazy. Why do you want to medicate him? You're giving him an excuse to be lazy. They often tell us. I've had a very, very, let us say, angry parent telling me that you are encouraging her to be depressed. She is not functioning. I am trying to motivate her, and you are saying it is okay to be like this. Because the girl was so distressed. She was saying that I'm such a hopeless person. She had a lot of guilt regarding her depression. She has bipolar depression, but because of the severity of the depression, she already had a lot of guilt. And on top of that, her parents were pushing her to do things which she was not capable of doing it. And it ultimately ended in her saying that, why should I live? I'm such a horrible person. So I was trying to tell her that it is okay to be like this. This is a temporary state and you will get better. And that really made the the father very angry and said, you are actually encouraging her to be lazy. So it's very difficult to explain this, first of all. And many relatives don't want their wards to be labeled as mentally ill. So they resist the diagnosis. That is one thing. And because a person is so functional in between, they often cannot accept that, oh, why? I don't think that person has a mental illness. So that is another thing. Whereas in schizophrenia or other chronic mental illnesses, person is always abnormal. Here you have periods of abnormality and then person is perfectly alright. So it's rather difficult to understand, especially bipolar 2. The stigma is always there. Nobody wants if you call it a neurological disorder, then people are a little more inclined to buy it. So that's what I often do. And it is. I'm not making a statement which is false. Ultimately, we will find out that all mental disorders have subtle neurological underpinnings in the form of at the molecular level. So we cannot see it in a CT scan or an MRI, but that doesn't mean the brain is not dysfunctional. The brain is dysfunctional at some level, on a molecular level, it may be, genetic level, it may be, or synaptic level, it may be. We'll find that out. We have not found it out. But it's definitely a neurological disorder. So I think there will be a time when the stigma will be less because it will be understood as a neurological disorder rather than a crazy person. So there is so much of, the mind is the least understood area of your organ, let us put it like that. So people do feel that it is something totally different from medicine or different from your body. It is something else. You're crazy or you are, possessed. No, that was an old concept, but it still exists in many, even with educated people, still go to the faith healer, they still go to the temples, they still go to the astrologer. So they are trying their level best to resist treatment, and we are trying our level best to give that treatment. So it's a constant struggle.
Yes, ma'am. Absolutely, it is a constant struggle. So now, one topic I wanted to ask you is that social media often glorifies mania as a phase of extreme productivity. What is the reality of manic episodes, ma'am?
Hypomania is a period of productivity, but once you get manic, you never do anything constructive. What happens is that you have so many ideas, but you don't follow through any of them. Lots of foolish decisions about finances. You have so much of optimism in you that you cannot just look at the other consequences of your action. So it becomes somebody who cannot judge properly. So there is a lack of judgment, there is impulsivity, and there is so much of pressure of ideas that you cannot complete anything. You start off things and you can't complete them. So it is not a period of productivity at all. It is not a period of creativity at all. It is a period of chaos and anarchy. So definitely not. That is a very wrong kind of understanding of. Now you're talking about If you're talking about hypomania, yes, to some extent, but you cannot control. Many patients have told me, "Can you put me in a state of hypomania?" So I said, "Sorry, I cannot control that. There's no switch where I say, okay, let us keep some rheostat where we keep it at hypomania and not mania." Yeah, it's a nice phase to be in hypomania. Yes, I agree with that, but certainly not mania. And there's no guarantee that this fellow will not, you know, go escalate his symptoms into mania.
Right. So, ma'am, now, how does bipolar disorder impact a person's work, relationships, and his daily life or his or her daily life? What can society do to be more supportive towards this?
Impact of the functioning, definitely, like I said, with all these symptoms, a person makes a lot of foolish decisions in his life and regrets them later, becomes depressed over them, starts feeling guilty about whatever he has done during his manic phase. So definitely it affects his entire life unless it is treated properly. That is definitely there. What can society do? Society needs to first of all be aware, understand, and support. So for that, a lot of awareness has to be. I think it has to come from us psychiatrists also. As you know, we have to have. We've been trying to create a lot of awareness about this, and I think compared to say 25 years back when I started my career, there is a lot of understanding, and that progress has been made. It's not that it hasn't.
Yes, ma'am, absolutely. So, my final question to you is: you have already talked a little bit about this with Dr. Raghu during the treatment and management, but what advice do you have for family members and caregivers of people with bipolar disorder? How can they provide the right kind of support?
Number one, they should get informed about all this from a proper source, not Google, because Google anybody can put anything. So definitely talk to the doctor about what is the how they can support the patient better. One is understanding, supervision of medication, insistence on medication, and allowing the patient to be not very overprotective at the same time being supportive. So this is a delicate balance that they have to. And when the patient is in an episode, they should understand that the aggression or the things that they say are not to be taken to heart, because that can actually affect a lot of relationships. The husband starts saying things to the wife which in the episode which she takes to heart, and then later on when it is over, then she thinks, oh, this is what my husband thinks about me, or the father or the mother. So understand that this is a phase where the person is not normal. So he or she may do things and which may be hurtful. So you should not judge the patient based on what he does during his manic episodes. So that is very important to understand the illness.
So, thank you, ma'am. You have covered, I think, something that goes very closely with psychiatry these days, as the topic of stigma. Thank you for your valuable insights, ma'am.
Thank you, ma'am. Thank you for the valuable insights so far. As a psychiatrist, which has been the most fulfilling part of working with the patients with bipolar disorders?
The most fulfilling part, I would say, with working with any psychiatric patient is that when they get better and they are functional and they are, when they come back to you and say that I'm doing this job very well, or I'm going to get married and I've got this, and I'm still taking my medicines and I understand what it is. So when you have that connection with the patient and they understand their illness, it's a teamwork then. It makes it so much more satisfying. I think that is the best time when people actually come back to you and say that I've not had any episodes, I'm taking your medicines, I'm doing great. And then you feel happy that you have helped somebody along their way.
On this World Bipolar Day, what is your message to the general public about mental health awareness and the importance of seeking help at right time?
Mental health is something that we all need to take care of. And lifestyle modifications are very important for those. Uh, those who are unfortunate to have relatives with mental health challenges and serious mental disorders, we cannot compromise on the medication part because these are illnesses. They cannot be taken as just something which happens. It's not like depression is not sadness. We all have experienced that. That is where the misunderstanding lies, because we normally have sadness, we normally have anxiety, we normally have a little euphoria at times when something good happens. But this is not to be confused with bipolar disorder or depression or anxiety disorder. When it is a disorder, it has to be treated. And the stigma related to mental illness, I think we all have to work for that, because there is a self stigma. Patients' relatives, patients themselves regard themselves as having something very bad, and it's almost they regard themselves as being tainted by mental illness. It is not so. It is not something which we can help. All of us can develop mental illness. So we need to be aware, promote the awareness, and reduce stigma and help those who are struggling. That would be my message for this year.
Ma'am, last but not least, what is your advice about to the young medical students and the post UG interested in pursuing the psychiatry as their career?
Like I said, if you want to explore the last unexplored frontier, then you are welcome to psychiatry, because everything else is a mechanical thing. You are studying the heart, you are studying the kidneys, they are all doing their function. They have parts, it's like a heart is a pump. So you're just studying the parts of the pump. I don't mean to demean any other profession, but for me, it is like this is something which is mysterious and challenging. So those who like mysteries and challenges, they are welcome to psychiatry.
So, as we come to the end of this enlightening session on World Bipolar Day 2025, I would like to extend my heartfelt gratitude to Dr. Bindu Menon for sharing her profound insights into bipolar disorder and its impact on mental health.
My pleasure.
Her expertise and compassionate approach have given us a deeper understanding of the condition, emphasizing the importance of awareness, early diagnosis, and the need for holistic management. Thank you so much, ma'am.
Thank you for having me here.
Now, bipolar disorder, like many other health conditions, so as you all know from this, is often misunderstood and stigmatized. But today's session has reinforced the fact that mental health is just as important as any other physical health. And with the right support and interventions, individuals living with bipolar disorder can lead fulfilling lives as well. It is our collective responsibility as healthcare professionals, caregivers, and members of the society, like ma'am, to create a more inclusive and supportive environment for mental health.
I would like to thank all the viewers, those who are watching this. I would like to thank ma'am for joining with us today. Your participation reflects the growing commitment for the mental health advocacy and education. At Medusane, we remain to be dedicated for providing a high quality medical education and fostering discussion in all the domains of medicine. If you found this session valuable, do stay connected with us for more such initiatives aimed at bridging the gap between the medical knowledge and the real world practice. Let us continue to break the stigma, spread awareness, and support those who are in need. Once again, a big thank you to Dr. Bindu Menon ma'am, my own HOD, and all of you, those who are watching this important conversation. Stay informed, stay compassionate, and let's work together for a healthier future. See you all in the next session. Thank you.